We live in exciting times, and we have exciting times ahead of us, at least concerning treatment of type 1 diabetes, and especially my subject today, diabetes and technology. When I started my career in pediatric diabetology in a big center in Germany 30 years ago, 1993, we treated children with type 1 diabetes with 2 to 4 daily injections. 4 injections were already quite modern. 4 to 8 capillary controls per day. We had no ultra-rapid insulin. They were on a quite strict diet. The glucometer took 2 minutes to show a result, and HbA1c goal was below 8%. Now, 30 years later, children with type 1 diabetes, at least in Europe, get CGM, continuous glucose measurement, right or shortly after diagnosis. We have insulin pumps with ultra-rapid insulin. We have automated insulin delivery systems. They are not really on a strict diet, and HbA1c goal is now below 7. So we see that all over in pediatric diabetology. There's an increasing use of technology, CGM and pumps, and hybrid closed-loop systems are becoming increasingly standard. Talking about Luxembourg, I work in Luxembourg. Last year, 80% of our patients were on insulin pumps, compared to 20% 10 years ago. 96% of our patients used continuous glucose measurements. 10 years ago, 8%. And 57% of our patients were last year on hybrid closed-loop systems. In 1993, the results of the famous DCCT study came up, and they compared, well, not many patients had pumps that times, so they compared multiple daily injections versus a strict treatment with injections to normally mixed insulin per day. And they showed that multiple daily injections, so-called intensified insulin therapy, showed a major reduction in the risk of long-term complications. And this resulted in recommendations about lowering the HbA1c goal. But lowering the HbA1c goal means that we need lower glucose levels. And in consequence, with lower glucose levels, we increase the frequency of, or at least the risk of severe hypoglycemia. And long-term follow-up studies show that more frequent episodes of severe hypoglycemia and or exposure to higher HbA1c levels result in an increased risk of cognitive dysfunction, especially memory, psychomotor, and mental efficiency. So the challenge of modern treatment of type 1 diabetes is to achieve acceptable HbA1c levels safely without severe hypoglycemia. But not all, it's all about metabolic outcome also, but it matters from onset. And children have onset at young age, and they have a long duration in the life of type 1 diabetes. And it's not only about retinopathy and nephropathy, it's also early onset type 1 diabetes is associated with up to 30 times increased risk of serious cardiovascular outcomes. So challenge of modern treatment of type 1 diabetes is to achieve acceptable HbA1c levels safely and from onset on. And it's not only HbA1c. Important for good metabolic control is also time in range. And that means the target of glucose levels between 70 and 180 milligram per deciliters. And there are recommendations, ATTD recommendation from 2019 about that. So this year, ADA, the American Diabetes Association, they say time in range is associated with the risk of microvascular complications and can be used for assessment of glycemic control. So, challenge of modern treatment of type 1 diabetes is also to achieve good time in range. The recommendation is more than 70% of all glucose values between 70 and 180, which is extremely difficult on multiple daily injections, as you know. There are a lot of studies about comparing insulin pump versus MDI, and to make it short, insulin pumps perform better. They improve clinical outcome, lower risk of severe hypoglycemia, lower risk of diabetic ketoacidosis, and better HbA1c levels. So talking about technology, this is first, I will show you insulin pumps. So this is a picture, a photo of one of the first insulin pumps in the early 70s in research. So nowadays they changed a bit. And we have pumps with tubes. We have tubeless pumps, so-called patch pumps. And we have ultra-rapid insulin, which matters a lot also in that treatment with insulin pumps with a so-called basal insulin. So the pump gives hourly a certain amount of insulin, and bolus insulin, that means the insulin amount for before meals. Can be also for corrections. So it's not all about pumps. In technology, we are also talking about CGM. CGM is continuous glucose measurement. It means that patients have a sensor under the skin which measures the glucose value, and the transmitter sends the result to a device, or more modern, to a phone. So it's a subcutaneous measurement of glucose, and it depends on the device every 1 to 5 minutes. And there is a very important time lag, 5 to 25 minutes, compared to the capillary value. So that depends on the speed of change in blood glucose. If you eat or if you do sports, it can vary, of course. And this is a physiological difference between capillary value and sensor value. We have that very often, that patients come back when they are on newly on CGM and say, this is really useless because we don't have the same values. Yes, that's normal. It depends on the situation. So there are two different kinds of CGM. There is the RT CGM, real-time CGM. It's an automatic measurement, and it displays the glucose value, the recent glucose value, on the receiver, or more modern, on the phone itself, on the mobile phone. And there are intermittently scanned continuous glucose monitoring. There the patient needs to scan the sensor to see the glucose value on the receiver or the phone. Both systems show alerts in case of high or low, and trends, arrows, with both systems. Here you can see the different systems. I think you have the same in Belgium. We have the Guardian Connect from Medtronic, the Freestyle Libre from Abbott, hopefully soon the Freestyle Libre 3, and the Dexcom. I know you have the one, or it's reimbursed. We have the Dexcom 6, and hopefully soon the Dexcom 7. For parents and caregivers, all these systems offer follower function. That means that the parent or several persons in the family or other caregivers, they can see the actual value on their phones. They get alerts as well. So this can be very practical for families with a very small child. It can be a nightmare for an adolescent. So the CGM shows the whole picture, in fact, like a film. And compared to finger sticks, the capillary control, which is more like a photo, you might miss unnoticed highs or lows just with the capillary control. Then they started to connect CGM to an insulin pump. And the first of those systems came up in 2009. It was called sensor augmented pump, with a feature of suspend on low. That means the sensor gives the information to the pump, and the pump reacts on this information. It was the very first time that an insulin pump, a device, reacted by itself on an information, on glucose value. And it was this suspend on low. In case of hypoglycemia. In 2015, there was the next generation suspend before low feature, which means that the pump suspends insulin when the sensor glucose approaches low limit in order to avoid hypoglycemia. In 2018, the first automatic insulin delivery system came. We call it also hybrid closed loop. And it's in fact also CGM connected to an insulin pump. You see here, one is the sensor, two the insulin pump. There's an algorithm in the insulin pump, and the sensor gives the glucose value information to the pump, and the algorithm in the pump is calculating, in fact, the insulin dose the patient needs and gives it via the number 3, the insulin catheter. So the hybrid closed loop means it's an automated basal rate based on glucose level and trend. So when the glucose is low, it won't give. Is it high? It will give insulin. But introduction of carbohydrates and boluses are still manual. So for meals, therefore hybrid closed loop. For meals, the patient still has to manipulate the pump. And it's not yet a fully closed loop system. So there are different stages up to a fully automated insulin dosing. I prescribed already step 1 and 2. And 3 is a hybrid closed loop. We have some systems on step 3. We have already some systems on advanced hybrid closed loop since 2020. And these are systems where the delivery is also for correcting bolus. So not only to maintain the basal rate, but also to give extra boluses in case of hyperglycemia. And step 5, of course, would be or will be fully closed loop systems where this AID system can recognize meals and deliver meal boluses to prevent hyperglycemia. And we are not that far from it. So what do we do in Luxembourg? When we have children at onset of diabetes below the age of 7, we all put them on insulin pumps. And then on CGM, and then we suggest an AID system a couple of weeks afterwards. It depends a bit on the situation in the family. Because it's at that age, the very young ones, it's very difficult to predict the amount and timing of meals. And they are usually better controlled with a small amount of insulin per hour. And this is very difficult to handle with pens and multiple daily injections. Because you give insulin per hour, and this is easier with the pump. And in beginning of diabetes, when the pancreas is still producing a bit of insulin, we call that the remission phase. There are very often in young children hours where they don't need insulin. So this is much easier to handle with an insulin pump. And they are not only, the care is not only given by parents, there's also crash, grandparents, other caregivers, and for them it's much easier to press on a button to give insulin than to inject each time the child. So when a child is above 7 years, we start on multiple daily injections, so once a day a long-acting insulin and then rapid insulins before meal. And within the following days and weeks, we suggest a CGM system, and then in the following months, we offer to try an insulin pump or to change to an insulin pump and AID system. Because we believe that they need to know how to use the pens when the pump doesn't work. And in remission phase, they are very stable in the first month and well controlled with MDI, so there's no real emergency. And we can give them time to think about it and to choose about future pump and CGM they really want themselves. So what kind of systems are we using in Luxembourg? We have 3 systems. They are all advanced hybrid closed loop systems. So we use for the smaller ones the Cambridge APS system. It's from 1 year on. It's the first CE-marked algorithm on a mobile application, and it gives insulin from a smartphone. You can handle the pump from the smartphone, which is extremely interesting for the parents. And we participated in many studies with this pump, and the feedback was very positive from family sides. And it is an interoperable system. That means it works with 3 different pumps and can be connected to 2 different sensors. So there is a choice, and that is called interoperable. We have another system, the T-Slim X2 from Tandem. It's up from 6 years on, and you need minimum 25 units per day, otherwise the system doesn't work. It's also an advanced hybrid closed loop system, and this here, this CGM, the connected CGM is the Dexcom G6 for the moment. And there's a third system, the Minimed 780G from Medtronic, and it's from 7 years on. You need at least 8 units per day, and it's also an advanced hybrid closed loop system, and it is connected to their own CGM, the Guardian 4. So with or thanks to more technology, the recommendations have also changed. And I mentioned already the change of HbA1c goal and the time and range recommendations. There is this year, the American Diabetes Association said even that AID systems should be offered for diabetes management to youth and adults with type 1 diabetes who are capable of using the device safely. And there are more and more discussions about a new target, or the time in tight range. That means with all these technologies, why shouldn't we aim to lower the upper limit and to come more and more to normal glycemia with our patients? So time in tight range would be between 70 and 140 milligram per deciliters, but it's not yet decided, but there are a lot of discussions about that. So what will there be in the future? There will be more pumps and AED systems operable with mobile phones, because this is clearly shown in studies too. Families are asking for that, and patients too. It makes it more discreet also. And there will be more systems interoperable. So there will be more systems where the patients can choose one day which devices they would like to connect. And there will be AID systems with patch pumps. And this year, by end of the year, there will be the first one. It's the Omnipod 5 that will come up here in Europe on the market, but it's not yet an advanced hybrid closed loop system. It's a hybrid closed loop system. It doesn't give correction boluses yet, but it's the first patch pump and AID. So in clinical trials, there is a lot concerning closing the loop. Each company will be the first, of course, so there's a big concurrence, and I think that is good for the patients. And they want to come up to a fully closed loop system without meal announcement, without any intervention, which is, of course, not so easy, but it's amazing reading those articles and seeing what they are really thinking about and how they come up to it. And what will also be in the future are the bihormonal pumps. So normally without diabetes, your sugar values are controlled by 2 hormones, by insulin and glucagon. And normally we treat our patients just with insulin. So there will be more and more pumps, and they are in the pipeline to use both hormones and even to connect it to automated insulin delivery systems. So, to pump or not to pump? I think there's enough evidence to join the team pump. But I don't have enough time to show all the work and the training behind, but it's really a lot of work and a lot of training, and not only for patients, parents and other caregivers, also for us as a team, and we learn with each new technology. And we have a lot of discussions if we should introduce new ones or not, because it's a lot of energy we put in it. And we have also our own hotline for troubleshooting, really used a lot. We have between 200 and 300 phone calls per month. And we offer, on top of that, also hotlines from the different companies when there's a technical problem. And this is only possible in a multidisciplinary team. Thank you. Or, as we say in Luxembourg, vielmals merci.